So lung cancer is usually considered a very hard topic, but today we're going to simplify it to remember it better. Lung cancers are usually associated with smoking. So with smoking, you normally get small cell and squamous cell carcinoma. And with non-smokers, you commonly get an adenocarcinoma. Now, before you get confused with the terminology, let's look at the four most common types of lung cancer. So the first two are squamous cell and small cell cancers. Squamous cell cancers are the second most common form of lung cancers, making up 20% of all types of lung cancers. And small cell cancers share about 15% of the lung cancers. Now, these two are characteristic for central growth of tumor, and as we said before, are commonly seen in smokers. Now, squamous cell cancers have a local growth, and this local growth eventually becomes a cavity, like something you see in TB, and so a surgical resection usually resolves the issue. But with small cell cancers, these are of a neuroendocrine tumor, and so they micrometastasize, usually to the brain, adrenal gland, and liver, the brain being the most common. And now, because they do metastasize and aren't localized, the most ideal treatment would be chemotherapy. Now, moving on, we have two other types of cancers to discuss, the adenocarcinoma and the large cell carcinoma. Now, these two are seen in non-smokers, and the growth is peripheral. Now, with adenocarcinoma, they have a unique trait of being able to spread via the airway contralaterally into the other lung. This is known as the transbronchial spread. For these types of cancers, a sputum cytology can be done and resection is used as a treatment. If these are not diagnosed on time, patients can end up having a unilateral pleural effusion, which manifests as trapepnea, so they have breathlessness in a lateral position. And large cell carcinomas are known to produce estrogen, and these manifest as gynecomastia. Now, to group this, squamous cell, adenocarcinoma, and large cell are grouped together, and the small cell is grouped separately. Now, lung cancer can be described in a lot of different ways and categorized in a lot of different ways. So today, for the sake of simplicity, we're just going to remember that small cell lung cancer is also known as oat cell cancer, and non-small cell lung cancer, it consists of squamous, adenoma, and large cell. We describe the four types of lung cancer by categorizing it according to the location of the tumor. So with the central tumor, let's see what things can manifest. So, central lung cancer is a tumor that develops on the large bronchus, accompanied by multiple symptoms. One of the first things you would see is an obstruction and difficulty breathing, so you would cough a lot. You might have bleeding, which would end up with hemoptysis, and the bronchial obstruction can end up with pneumonia or abscesses. When a central tumor develops in the main bronchus, you could have a thoracic duct compression, known as chylothorax. The other anatomical features around that area would be the superior vena cava. So if a tumor is large enough to compress it, you get what's known as the superior vena cava syndrome. It impairs the venous backflow and causes congestion in the head. So you'll end up with facial plethora. You can see distended neck veins, and there'll be a non-pulsatile jugular vein pressure. The other thing in that anatomical location would be nerve. In this case, let's say the right laryngeal nerve gets compressed, then you'll end up with hoarseness and vocal cord paralysis. Around that area, you also would get the esophagus, so a compression of the esophagus would lead to dysphagia or a tracheoesophageal fistula. Now remember, all of these symptoms will make sense once you understand the anatomical location of the tumor and what surrounds it. So with peripherally located lung cancers, the most common area is the apical, and so apical lung cancers are also known as Pankos syndrome. And what this does is that it ends up compressing the sympathetic chain behind by the spinal cord and results in a variety of symptoms. The first one would be Horner syndrome. So you get ptosis because the mular muscles get affected. Meiosis, and that's because the sympathomimetic system is compromised, and so the opposite is induced. You also get anophthalmomas, which is basically sunken eyeballs, and anhidrosis, which features as lack of sweating on one side of the face. And you also have a loss of ciliospinal reflex. Now, all of these can be remembered with the mnemonic perfect meal. So there's P for perfect and MEAL for meal. When you get an apical tumor, the other anatomical location is that the tumor can grow around the brachial plexus, and it can compress the lower brachial plexus, which is the C8 and the T1. And that would essentially affect the shoulder and the arm. So you would get paresthesia, paralysis, and atrophy of it. Peripheral lung cancers on the lower lobe would involve the pleural space, so you would have effusion. You can also involve the pericardial sac, so you'll end up with pericarditis and pericardial effusion. Now, if you've noticed, two of the lung cancers that we discussed earlier also have involvement with hormones and endocrines. So now that we've learned that lung cancers can also produce hormones and antibodies, these can contribute to something called the paraneoplastic syndrome. Now, learning paraneoplastic syndrome is important because it can manifest as cachexia, increased risk of thrombosis, and increased risk of embolism. So the first hormone that we're looking at would be antidiuretic hormone, and this manifests clinically as the syndrome of inappropriate antidiuretic hormone. And these can be caused by small cell, also known as oat cell cancer. The next hormone would be adrenocorticotropic hormone, and this one manifests as Cushing's syndrome, and this is also caused by small cell and oat cell cancer. Estrogen, as we spoke before, manifests as gynecomastia and is caused by large cell cancer, and the parathyroid hormones can be stimulated, manifesting as hypercalcemia, and this is caused by squamous cell cancer. There are two other significant manifestations of lung cancer. One is that lung cancers can damage the neuromuscular junction, and this is known as a Lambert-Eaton syndrome, and it's quite similar to myasthenia gravis. It results with peripheral neuropathy and cerebral degeneration. The other point is that these can also result in hypertrophic osteoarthropathy. This manifests with clubbing of the fingers and swelling and pain in the joints. So we have all these various symptoms and manifestations of lung cancer. So what's the workup that we do for these patients? Most commonly, you do a sputum cytology and is repeated 3 times. This is helpful and indicative of adenocarcinoma. You can also do a high-resolution CT, which will help you understand the size and extent of destruction of the tumor. You obviously have to do a biopsy for tissue diagnosis. You can do that with flexible fiber optic bronchoscopy, and is usually needed to get the diagnosis. A PET scan will help you find distant metastasis. Lab tests will help you identify if there's any hormonal involvement. The TNM staging system helps you classify the extent and the spread of the cancer. The T describes the size of the original tumor and whether it has invaded nearby tissue. So the general outline is that for TO, there's no evidence of tumor. TIS is carcinoma in situ. And T1, T2, T3, or T4 indicate a primary invasive tumor, for which a higher category generally means an increasing size and increasing local extension, or both. The N categorizes regional lymph node involvement depending on its existence and extent. NO means there's no regional lymph node involvement with the cancer. N1, N2, and N3 are evidence of regional nodes containing cancer with an increasing number or an increasing regional nodal group, or the size of the nodal metastatic cancer deposit. M categorizes specifically whether distant metastasis is present. MO means there's no distant metastasis present, and the M1 category may be specified further according to the location of the distant metastasis. Treatment is really straightforward. For small cell cancer, use chemotherapy. You can also include cisplatin plus irinotecan. Non-small cell cancer is usually treated surgically, and they're also given 3rd-generation chemotherapeutic treatment. And that's the end of the lung cancer discussion. Thank you for watching.